So I talked about the indication for radiation after neoadjuvant chemotherapy. So basically, the indication for radiation was always based on having surgery up front, because the surgery will give us a lot of information to decide whether we need to give radiation or not and where. If there is a lumpectomy, we give radiation to the breast for sure, but it's not clear whether we need to give radiation to the lymph nodes around. And if the patient undergoes mastectomy, we don't know whether we should give post-mastectomy radiation or not. So everything, all the indication was always based at presentation of the patient with the type of tumor, with the extent of tumor, and doing surgery up front. Nowadays, a lot of patients undergo chemotherapy up front. So the tumor and the lymph node status starts to change. So what do we do if all the information we have is based on surgery first? Now we are not doing surgery first, so things got confused. So what I try to explain that first, there is a big study in the US which is addressing this issue, and phase 3 study, like a randomization between radiation, no radiation, based on a clinical situation. The specific situation that I addressed yesterday was that if a patient starts with a palpable lymph node, like cancer extended to the lymph node, and it's documented with a biopsy, so we are sure she has a positive lymph node, and undergo chemotherapy, and then when she does surgery after that, the lymph node disappears, sort of like the whole cancer disappears. So what should we do? Should we still give the radiation and consider the indication based on the original presentation, or now the cancer had disappeared, why do we need to give radiation? So this is the question which we try to answer. So if the cancer remains in the lymph node after the chemotherapy, we have to give radiation. If it disappears, we just don't know. So sometimes we do, sometimes we don't, because the study now is looking at this. But I personally, I lean towards being safe, more safe, and I just give radiation if I have documentation that the lymph node was positive. So that's what the talk is about. I think we always involve the patient in the decision. Sometimes the decision is a clear cut from data, but when the data is blurry, when there is no data, when it's a gray zone, we just don't know the answer. I think involving the patient is extremely, extremely crucial, because some patients will tell you, I want to do everything. I want to go as far as possible. Another patient will say, unless you are sure, I prefer to have a good quality of life, and if you are not sure that this treatment is necessary, I don't want it. So this choice makes things really very clear for us. And we just involving the patient is very important, actually mentally and emotionally for the patient and for the physician too. The culture is completely different. So in Boston specifically, actually among, it's like Boston, New York, the intellect of patients is very quite high. They read a lot before they come to you, and they ask questions as if they give you an oral board exam. Why do you do this? How do you do that? What is the data? I mean, that's what I am expecting when I go back to Boston, actually the majority of patients. In Egypt, and I'm originally Egyptian, it's a completely different culture. It's sort of, you are the doctor, you are the one who knows, and just take care of me, and I trust you. And that's the other side of things. And I also trained a lot in France, and I know back then when I was resident, the French culture is rather closer to the Egyptian culture. They just trust you, and they tell you just do what you need to do. But I hear from my colleagues this has changed now. that they started to read and to question you, and you have to explain all what you need to do. So it's a completely different world, actually.